Thank you very much for the opportunity to speak here this morning. My name's Megan Best. I work in a palliative care unit and I care for people who are soon going to die, and it's a privilege to look after people in their final illness. But today I've been asked to talk about euthanasia. It's a contentious issue which is widely discussed, and for over 2,000 years it's been a prohibited practice for health practitioners. But now, why, at a time when we have more medical cures than ever before in human history, are people talking about the need for a law for doctors to be able to help their patients to die? Euthanasia and physician-assisted suicide have been legalised in a number of overseas jurisdictions, and politicians in this country are being criticised for ignoring the will of the public because we're told that something like 85% of the population are in favour of euthanasia. Well, I've discussed euthanasia on Talkback Radio in Sydney many times over the years. And I believe that what this statistic shows is not so much how many people really want to be assisted in their dying, as the fact that many people don't really know what happens at the moment in end-of-life care. Confusion abounds in the public understanding regarding what is possible under current laws and what the legalisation of euthanasia really means. And I believe that this is a huge problem in the end-of-life care at the moment. So something like today is a great opportunity to start to set some of these ideas along the right track. Now, euthanasia is taken from the Greek. It means good death, which is really unhelpful because everyone involved thinks that they're campaigning for a good death. In fact, deciding what constitutes a good death is really at the heart of the whole debate. I define euthanasia as an act where a doctor intentionally ends the life of a person by the administration of drugs at that person's voluntary and competent request for reasons of compassion. A doctor killing a patient, no more, no less, usually because they mistakenly think that that's the only way they can relieve the suffering. In physician-assisted suicide, a doctor intentionally helps a person to commit suicide and is distanced from the act, but it's morally no different from euthanasia as the motive, intention and outcome are the same. So since they're similar in moral terms, I'll be using them interchangeably today. But in order for you to really understand what the euthanasia debate is about, you also need to understand what euthanasia is not. Euthanasia is often confused with withholding or withdrawing futile or burdensome treatment. We've already heard about this today, but when a patient is in the terminal stages of their illness, a time may come when treatments aimed at cure either no longer work, they are futile, or the burden of side effects cancels out any benefit of that treatment. At this stage, the treatment may not be so much prolonging life as prolonging the process of dying. But avoiding these treatments is not euthanasia because our intention is not to kill the patient, but to allow the underlying disease to run its course. No mentally competent person in New South Wales has to undergo any treatment they don't want, even if refusal of that treatment means their life will be shortened. All mentally competent adults have that right of refusal. And euthanasia is not switching off the life support machine, even when we know it will lead to the death of the patient. It's not flicking the switch that kills the patient. It's the underlying disease that kills the patient. That's why they were on life support in the first place. Euthanasia is not the administration of medications needed to ease pain and discomfort at the end of life. At the end of life, some patients do develop distressing symptoms, and we want to relieve that distress. Depending on the nature of the symptoms, the treatment will vary. Sometimes sedation or large doses of analgesia may be required, but comfort is always the goal. It's not euthanasia because the intention is not to kill the patient, but to alleviate their distressing symptoms. Now, some people who use these words voluntary, involuntary, passive and active, they say, well, this is called passive euthanasia because of a myth in the community that when we give morphine, it shortens the life of the patient. They argue, well, if we already practice that type of euthanasia, why can't we have the other type of euthanasia, which they call active euthanasia? You see the problem. The terms are unhelpful. But it's all based on a myth that morphine shortens the life of the patient. But morphine given in the doses needed to relieve pain does not shorten the life of a patient. Our research suggests that it may actually increase survival. I can't believe I still have to say this after 20 or 30 years. None of these things is euthanasia. None of these things require a change in the law. They are legal and ethical options which are standard practice at the end of life and which many patients don't seem to be aware of. My patients are delighted when I tell them that they can stop their chemotherapy if they want to. They didn't realise they had that choice in many situations. And when the public has a better understanding of what happens at the end of life, it reduces the call for euthanasia because there's less suffering and people have an increased sense of control. Anyway, in those places where euthanasia is legal, pain is not a common reason why it is requested. Despair and loneliness, fear of the future and fear of being a burden. These are the reasons why people request euthanasia. So it's not a failure of medical care which has led to call for euthanasia. However, it may be a failure of our support for the terminally ill. Because it's true that many people experience pain and suffering when they're dying, and this has led to a situation where too many people have seen someone die a bad death. Maybe they were in pain. Maybe they lost their dignity. Maybe they were in emotional turmoil. I'm sure this is the experience of some people in this room today. It shouldn't happen, but it still does, and it's an important factor in the call for euthanasia. It's been the experience of some of the people campaigning most energetically for the cause. We must do better. We've already heard about palliative care this morning, and with modern medicines and procedures, we can control the majority of symptoms. And I know that many people think that they would want the option of euthanasia when they face their own death, but evidence suggests that many of them won't. Because if you look at the people who are staring death in the face, people like my patients, most of them think quite differently, even if they're signed up members for Dying with Dignity. A study in Sydney showed that the number of people requesting euthanasia in a palliative care service was 2.8% when they first showed up, falling to less than 1% once care was started. Less than 1% of patients persisted in their request for euthanasia. And this is certainly my experience. The third patient in my career who asked for euthanasia did so about a month ago. And after I treated his pain, he's decided he has enough energy to sue his local council for a tree in the backyard. Chances are that most of those 85% of people interviewed were quite healthy, and they don't realise what it will be like at the end. And it's not surprising because most Australians don't have contact with death until very late in life. Most people have never seen a corpse. And I'm not saying that no one ever rationally requests euthanasia. I'm just saying that the polls are very misleading regarding the extent of public support at the very end of life. But knowing that there is an alternative to killing a suffering patient is not the only reason why I oppose euthanasia. My concern is also for the social consequences of legalisation, which have been seen in those places where euthanasia is law. One such case is the Netherlands. Euthanasia was decriminalised in Holland in 2002 and was intended initially for those terminally ill patients who were mentally competent and experiencing intolerable suffering at the end of life, as for most legislation that's been passed in this way. But by the time the law had passed, the courts had already legitimised the death of patients who were not terminally ill. Then they allowed it for people whose suffering was not physical. and then for the mentally incompetent. And in 2005, a Dutch hospital published their guidelines on how to kill disabled newborn babies. This is what they mean when they talk about a slippery slope. Now, proponents of euthanasia will tell you that legal guidelines will prevent abuse from happening, but the facts suggest otherwise. My information comes from government reports. Their first report for the Dutch government was published in 1991. This one from 1994 shows that in that previous year, about a third of deaths, the dark blue there, occurred without the knowledge or consent of the patient. Now, you might think that might have been a one-off, but in every year's report since then, this large proportion of patients being killed without their knowledge or consent continues to appear, and it's all under the stringent guidelines in Holland. In places where physician-assisted suicide is now legal, such as in Oregon, USA, the reporting processes are also making it quite worrying in terms of what is actually happening, in terms of the legal guidelines being in place but not being followed. It's also worrying to know that another research report showed that euthanasia was more popular with relatives than with patients. This is the experience of those in places where euthanasia has been legalised. Don't count on your doctor necessarily being a protector of life. But the main argument I expect you'll hear today is that of autonomy, the right of people to choose the timing and manner of their own death. The focus on individual values has become increasingly important in our society, and it's at risk of overwhelming our concern for vulnerable people who are at risk of a death which was neither requested or approved. We can't please both groups, both those who want euthanasia and those who are at risk. But remember, this debate is not about whether euthanasia can ever be justified on an individual basis. Of course it can. I'm sure there are many people in this room whose own ethical system allows them to say that euthanasia is the right choice for them. But that's not what this debate is about. We also know that you can kill yourself, and sadly around 2,000 Australians a year already do this. But surely our greater responsibility is to protect those who can't protect themselves, people like my patients at Greenwich. And very sadly, those people that less than 1% who persist in their requests will not be able to have what they want, and that's terrible for them. But I believe that as a society we need to protect vulnerable people who may not be able to protect themselves. And the reason I bring up this information is because it is the main reason why government reviews in many countries, including the UK, Canada, France and Australia, to name a few, have rejected calls for the legalisation of euthanasia. And why is it when an apparently healthy person says they want to die, we rush to intervene and get psychiatric help? But when someone with cancer says they want to die, we want to change the laws so that we can help them kill themselves. We know from research that up to 45% of cancer patients have depression, and one of the symptoms of depression is a desire to end your life. Research in Canada has found that requests for euthanasia is closely associated with clinical depression, which is a treatable illness. Why is this group of patients being treated so differently? Why is this not a psychiatric emergency? But it's of even more concern when we find from research that patients regularly change their mind about what is tolerable, and what might seem intolerable at one point may not be so bad when you actually arrive there. We can't be sure that those persons with a death wish, even if they genuinely meant it at the time, wouldn't have changed their mind if we'd just waited a bit longer. But I think the main issue is that in the end, dying is scary. Dying forces us to face the big issues of life. What does it all mean? What are we doing here? Western society is struggling to answer these questions. We're youth-obsessed and death-denying. We don't know how to die properly anymore. I think we could learn to die by example, but we don't see examples because everyone's in hospital at the time of their death. Death is divorced from everyday life. Furthermore, we're immersed in a culture of comfort where we're not used to suffering and we find it difficult to tolerate either in ourselves or other people. But understanding suffering is important because it may be that what people are requesting in the call for legalisation of euthanasia is not so much a right to die, but a right to avoid the process of dying itself. In our community, the fear of dying is promoted by numerous accounts of pain and misery experienced as life draws to a close. And so I expect you'll hear from my Dying with Dignity colleague that palliative care is not sufficient to deal with suffering that can be associated with dying. I agree. But then suffering is not a medical problem. There is no medical answer. Suffering is an existential problem that extends beyond physical pain. It's influenced by psychological, cultural, and spiritual factors. Let me give you an example. Imagine we have two women with the same amount of physical pain. One's in labour, she's having a baby, and the other one's dying from cancer. The woman in labour knows the reason for her pain is the fact the baby's coming and soon the pain will stop and she'll have her baby in her arms. The woman with cancer knows the thing causing her pain is the thing that's killing her and it's never going to go away. So you can see that even though they experience the same amount of physical pain, the woman with cancer is suffering more. Often the physical symptoms can be dealt with and the suffering may well remain. I recently reviewed over 6,000 research articles on the topic of suffering. It is generally understood as a loss of personal integrity because of the inability to cope with the circumstances someone finds themselves in. It's experienced by the whole person, not just the physical dimension. And interestingly, the most effective treatment that's been found for suffering has been a psychosocial intervention where patients are given the opportunity to reflect on their lives and the legacy which they are going to leave, and so find meaning in the experience they are undergoing. Care needs to be given in all dimensions of the person, which is why a multidimensional palliative care service can be of help. But when suffering has meaning, it can be tolerated. It is possible to come through suffering, though professional help may be required. I believe our challenge today is to think of a way to revolutionise the care of the dying, not legalise an act which would all too easily substitute for the care, compassion and community that people need in some of the most difficult moments of their lives. Rather than legalising euthanasia, I would like to suggest a better way. I like to see a time when we might be able to recognise the process of dying for what it is and align our goals appropriately, as done in a colleague's practice in Western Australia. The first step is to recognise someone is dying, which, as we've already heard, is not always done well in hospitals. We change our goals. We stop giving treatment that isn't helping. We stop taking blood samples for tests which aren't going to change what we're going to do. We start to think about ways of keeping people comfortable, of supporting their carers, and in the end, we allow natural death. I don't know how many dying patients I've cared for over the years, but it must be in the thousands. I've had people say, I wish I was dead. And when I say, I'm sorry, but you know euthanasia's not legal in New South Wales, they say, well, of course not. Do you think I'd speak like that if it was? I can see that approaching your own death is never easy, and we have lots of work to do. But let me leave you with a quote from a pioneer in the field, Professor Balfour Mount. Healing is a relational process involving movement towards an experience of integrity and wholeness, which may be facilitated by a caregiver's intention, but is really dependent on the potential within the patient. It is not dependent of the presence of or the capacity for physical well-being. Indeed, it's possible to die healed. Thank you.